So hi, good morning everybody. This is Riccardo Bertolo from the UROonco platform Kidney Cancer. We have the pleasure today to have with us at the UROonco meeting in Budapest Professor Camillo Porta, who is a full professor of medical oncology and chair of the Division of Medical Oncology at the University of Bari. Definitely a key opinion leader in the field of renal cancer, member of the ESMO Scientific Committee, and a member of the guideline panel for both the ESMO and the EAU renal cancer. So, Professor, today we enjoyed a lot the dedicated session to locally advanced and metastatic kidney cancer, and we heard a very interesting discussion. So, I'm asking a couple of questions to you.
Sure.
In the era of the combo therapies, we have, many patients treated with combination of immunotherapeutic agents and anti-angiogenic drugs, but still we have, nice data for patients treated, good risk patient treated with monotherapy with standard TKI such as sunitinib. So why do we have to choose a combination therapy, also in light of pharmacoeconomics thoughts?
Yeah, that's a very good question. We know that immune-based combinations does not work too well in good risk patients because good risk patients are characterized by a tumor biology that is not inflamed, meaning that immunotherapy works definitely not as well as in patients with an inflammatory microenvironment that are, according also to the NDC classification, intermediate and poor risk patients. So we have to treat patients with good risk features with monotherapy. I would say no, because ultimately all the studies of combinations showed an overall survival benefit in the intention to treat population. That means the overall patient population irrespective of the activity in the single subgroups. So I would use more confidently the combo. In some patients, frail patients, elderly patients still needing treatment, we can discuss about the possibility of using a monotherapy. But in the general population, I would say no, because I want to have the overall survival benefit, and we know that no of the TKIs tested over time ever improved overall survival.
Okay. Thank you. And what about the patients who are relapsing, who are progressing after you use the combination, including immunotherapy? So which is the best way to treat them?
It's a difficult setting of patients because the data available till now are not so many. We know that we can use any VEGFR TKI not used within the combination. And we know that we can achieve some kind of benefit, not huge, to be honest. Or we can use a combination of one TKI and one mTOR inhibitor, that is the lenvatinib everolimus combination. And in those countries where this is feasible, because it is not feasible everywhere, we can also use another immune-based combination. But I think that the vast majority of these patients are going to receive in a second-line setting monotherapy with a TKI.
Okay, thank you. And I'm asking you as a medical oncologist, how do you see the indications for cytoreductive nephrectomy today? So if you see indications, do you see as a first-line treatment rather than just a palliation in patients with symptoms?
Well, we have data also in this era of immune-based combination that cytoreductive nephrectomy has a role as an anti-tumor strategy. For sure, we know that the problem is when to perform it. Given the available data, I think that the need for an immediate cytoreductive nephrectomy is decreasing, although some patients should be palliated by means of cytoreductive nephrectomy. I think that we can test the patient with a combination, and then in the case of an inadequate response, move on to perform cytoreductive nephrectomy plus or minus metastasectomy in order to try to use all the weapons in our hands in order to improve as much as possible survival.
Okay, thank you. And another point that I'm very interested into and was partially discussed during the session, the plenary session, is today we have approved the pembrolizumab to be used after surgical patients with locally advanced kidney cancer, but there is the problem that sometimes we are missing a couple of metastatic patients who are progressing to be metastatic. So which is your standard to reassess, to restage the patients after they have received the surgery?
Well, given the fact that usually often metastasectomy is performed delayed as compared to an intervention on the primary tumor, I always restage patients. And in the case we discussed within the panel, especially if the tumor has a sarcomatoid component, because we are talking about a very aggressive tumor. The problem in this setting is how to deal really with M1 NED patients. They are metastatic, although free of disease, so should we use pembrolizumab as an adjuvant, or should we move directly to a first-line treatment? We do not know. The risk, of course, especially in the case of aggressive tumor, is to under-treat with adjuvant pembrolizumab, and then having also nothing in our hands to treat the patient in case of progression. So this is something that should be still defined.
Thank you very much for your
My pleasure.
answers. It was a pleasure to have you. Thank you.